I'll go ahead and introduce our two presenters for today. We have Dr. John Bridges. John Bridges is an assistant professor in the Department of Health Policy and Management and is co-director of the MHS in Health Economics in the Bloomberg School of Public Health. The founding editor of the Patient-Centered Outcomes Research. Dr. Bridges' research focuses on the use of novel scientific methods to measure how patients and other stakeholders make complex decisions in health. And Dr. Anita Smith-Everett. Dr. Everett is the section chief of the Johns Hopkins Bayview Community and General Psychiatry. She's on the faculty of the Johns Hopkins School of Medicine and the Bloomberg School of Public Health. Her current area of research is the health behavior of individuals with long-term mental illnesses. Prior to joining the Johns Hopkins staff, Dr. Everett served as the chief medical advisor to the Federal Substance Abuse Mental Health Services Administration and as the Inspector General to the Office of the Governor in the Department of Mental Health in Virginia. Dr. Everett is a distinguished fellow of American Psychiatric Association and serves on the board of the American Association of Community Psychiatrists. She's president of the Maryland Psychiatric Society. She's currently engaged in a number of international projects which have included consultation with the Ministries of Health, Department of Mental Health in Iraq and Afghanistan on the implementation of mental health services in these countries. With that, I'd like to hand over the floor to Dr. Everett.
Well, thank you very much. It's a pleasure and honor to be here this afternoon. I think Dr. Bridges and I are going to talk in two sort of parts today. I'm going to be providing a little bit of a broad overview regarding patient-centered care and what that is and how that fits into contemporary mental health services, as well as a little bit of an introduction to a project in particular that we're working on. And then Dr. Bridges is going to give a lot more detail about a project that he's working on that relates very specifically to patients' capacity and expression of preferences with regards to certain aspects of their care. I have been told that this is the first time in a long time that there's been a talk on mental health, so if you'll indulge me, I do have a little bit of background information on where we are in the current state of things with regards to public mental health services as well. So thank you very much. Let's see, let me begin. So I've divided my remarks into two broad areas. The first is foundational concepts, and the second is a little bit of a description about the program that we have at the Community Mental Health Services here at Johns Hopkins that we provide. Under foundational concepts, I'll cover just a little bit about my perspective as primarily a clinician on what constitutes population health and how we think about that. A little bit on health literacy, health behavior, and then I want to make sure that the audience is a little bit familiar with the concept of recovery, which is an important concept in contemporary mental health services. And then with regards to access to wellness, a little bit of a description about the problem that the program is set up to address and the techniques that we've used in addressing those, which incorporate person-centered care and the recovery sort of concepts. So foundational concepts, the first thing I want to talk just a little bit about is what is person-centered care. One of the ways that I find useful to organize information about population health is in 4 areas, and I realize I'm speaking to an audience of experts in this area, but this is a way for me as a clinician and program organizer that's useful. So I think of that as having 4 elements: research, clinical care, health promotion, and health literacy. One of the ways that I organize this is in terms of the elements that are involved, and so I've created this sort of equation, if you will, that has to do with what the person brings to the health arena, that is their component of overall population health, the person having components themselves of health literacy and health behavior, as well as what the physician and or healthcare system provide. Those come together to provide the overall mechanics of health. Those two things are influenced by the other 2 factors, which I consider to be research. So there's an atmosphere of research that informs both of those systems, and research more directly informs physicians and healthcare systems, but it also has some influence directly on what the person brings to the system. And then the other atmospheric influence has to do with the health promotion or the work of public health practitioners, and I sort of submit that that's more directly related to influencing what the person brings into care, and less so, but also focused on what the physician and the healthcare system. So there's these relationships, I guess you'd say, in what elements influence overall population health. What person-centered care does then is focus there at the top. I've sort of duplicated that basic equation there. It focuses much more squarely on what the person brings to healthcare, and that's a really important concept. Not so much what the healthcare system does, but the healthcare system in reaction to what the person comes into the health system with. So one of the ways I think about this is person factors that are modifiable. We're familiar in our field with thinking about risk factors that are modifiable and risk factors that are non-modifiable. Eminently modifiable person factors include the health literacy, or the core knowledge that a person walks into the health system with, and their health behaviors, the actual ways, the things that they do that relate to their health. Less modifiable person factors include the environment that they come from. We work in our community mental health center with a number of socioeconomically challenged individuals, the friends and family, the environments that people come from, the resources that they have, and the access that they have to healthcare systems. So those are somewhat modifiable, but less so than directly impacting the person with regards to person-centered care. And then there are also our preferences in life experience, which are not as immediately modifiable as the other factors. So person-centered care has an impact on health systems and physicians and providers. It's that second sort of circle in the equation diagram. It's resulted in systems and physicians and providers focusing more directly on attending more consciously to person-centered care, results in physicians and healthcare systems looking for ways to increase health literacy and to induce positive behavior to improve individual and population health outcomes. That's an important trend overall in the broad field of health. We're more and more recognizing, in other words, that the critical role of the patient with regards to engaging more fully in their own health care, which adds to the population-based health care. There are a number of things, as sort of an example of that, there are a number of things in the recent Healthcare Reform Act, or the Patient Protection and Affordable Care Act, that create incentives for systems to induce or promote health literacy and health behavior. And one example of that is the concept of the medical home, which is pretty prominent in a number of different pieces of the Patient Protection and Affordable Care Act. There's some shift away from straight-up fee-for-services, and fee-for-services sort of reinforces the idea that you're sick, you come to a healthcare system, and you get well, rather than working overall more globally on your health behavior and health literacy. So it's a shift. I'm suggesting, I guess, that this is a shift, a large frame shift, and that person-centered care has a tremendous amount to do with catalyzing a shift away from direct fee-for-service style healthcare encounters. A second foundational concept that I want to just share a little bit about is what is community mental health for this audience that are not, I'm assuming, not primarily mental health providers. I want to give you a little bit of an update on where we are in the field of what community mental health is. I have a couple slides that reflect that. So community psychiatry, many of us in the field sort of attribute that or date that back to about 50 years ago when President Kennedy signed what's called the Community Health Construction, I think it was called the Community Health Construction Act. It was one of the last things he did before he was assassinated. It set aside funding, federal funding, for the building of community mental health centers around the country, and he had this vision as a part of his frontier policy that had to do with the whole new age in mental health, and that being more individuals leaving institutions and being able to be treated in community mental health centers. It set aside three sort of concepts that are very much alive and well in community mental health today. Those have to do with community mental health centers having a primary role in the care and treatment of individuals with enduring mental illnesses or long-term mental illnesses. Sometimes in federal and state documents they're called SMIs, or serious mental illness, or SPMI, serious and persistent mental illness. Community mental health centers is part two, sort of designed to work with individuals that come from disadvantaged socioeconomic status, and also to consider the population at risk. Usually in the case of community mental health centers, that has to do with needs of the community, the local community in which the community mental health center resides. It might be a county-based population, and in some cases it's a state-based or other combination of local governments that have to do with community mental health center functions. Integration of care is consistent with our roots as a specialty component of public health. So actually many functional community mental health centers started as outshoots of the public health system, the county-based public health system around the country. This is just a broad overview of community mental health in Maryland. Maryland has roughly a population of about 5.3 million. The latest statistics I could find, although I'm sure they're more current than this and have grown, but in 2007, 94,000 Marylanders were served at community mental health agencies, just to give you an idea of the scale and scope of just the public-funded clinics. State psychiatric hospital inpatient census is rapidly declining, and what is happening in Maryland, which is the case around the country, is that the types of individuals that are left in state facilities are much more likely to be forensically involved and more or less compelled to be there in a different way than what might be called civilian mental illnesses. And so the role of community mental health centers has actually become stronger in the last 20 years or so in our general field. So my point in this is to remind everyone or let you know that community mental health centers are alive and well, even though we tend not to be funded extremely well, which is the case for a lot of public services. The last foundational concept I wanted to talk just a little bit about was what recovery is. Recovery is very much like a patient-centered orientation. It's a movement that's been around, or sort of a thought process that's been around in community mental health for probably about 20 years, but has really gained a momentum since 2003, when the President's New Freedom Commission on Mental Health Services squarely promoted recovery as a concept. That was a report that came out in 2003, and really since then, many of us feel like we've reached what might be referred to as a tipping point with regards to recovery being made active in and visible in a lot of the way community mental health services are structured. Depends on the idea of empowering consumers to feel like they have a role in and responsibility in directing their own care and engaging in their own mental health care as a part of it. The tagline that I like is actually a tagline that used to be Home Depot's tagline that is, "You can do it, we can help," and that's what I try to sort of work with our staff on as a way to sort of manifest recovery. The concept of, yes, you may have some disabilities, but there are abilities that you have, and we need to work on how to rally and coalesce your abilities so you can move on with your life and not be held back by the illness at hand. So recovery is an important concept, active engagement of the consumer in their own life and illness management. And also, by way of reminder for public health practitioners that are familiar with the concept of chronic care, I just wanted to remind everyone that many of our conditions are in the category of chronic care. They're enduring processes for the most part, with varying degrees of remission of symptoms. The picture that I have there is a copy of a front page of a journal that is very sort of proactive and speaks to or represents this kind of spirit of "you can do it, we can help," what the recovery movement is all about. And it's a very good publication that's oriented toward consumers. That's the end of part one of my talk. What I want to do now is just tell you a little more specifically about a program that we're working on out at our Community Mental Health Center here at Johns Hopkins on the Bayview campus. What I plan to do is talk a little bit about the problem that the clinic is set up to address, talk a little bit about the access to wellness model that we've evolved, and then just I'm in the very early stages of compiling results on our information, so I have a few results of the program so far. So the problem that we've oriented ourselves to work toward with the Access to Wellness program is the poor health or the health disadvantage that individuals with long-term mental illnesses have. So persons with mental illnesses are very health disadvantaged. They die an average of 25 years earlier than the general public, and they die of the same general health conditions, many of which I will argue, and you'll sort of realize when you see the list, have modifiable risk factors that with strengthening of health literacy and health behaviors can be effectively modified. Persons with mental illness often have access and quality issues with traditional primary care, and they have health literacy and health behavior special needs, so to speak, some of which are related to the concentration and conditions of their illnesses, some of which are related to other factors in their lives. So this is just by way of a reminder what the all-cause mortality is in the United States in a rank order here. Cardiovascular, number 2, cancer, stroke, pulmonary conditions, accidents, and diabetes. Persons with mental illness die of the same causes and in the same rank order. The only difference with mental illnesses in a scale on this level is that the accidents is a slightly higher proportion, but it still doesn't outrank pulmonary conditions. And so accidents in this category includes motor vehicle accidents and other accidents like that, as well as suicide. So it's very clear that the number one cause of death in people with schizophrenia and bipolar disorder, some of these longer-term conditions, is not suicide. It's health conditions, physical health conditions. This is a slide just by way of a reminder. Probably many in the audience actually contributed to some of the data that has to do with the World Health Organization's life expectancy at birth. This is a little bit older, so it's from 2003. But I have it as a reminder when I talk about this subject to remind us that although we in North America are generally in the dark blue, which is longer life expectancy, good health in other words, our folks with serious mental illness in the United States are like much of the orange areas of the world, sub-Saharan Africa, in terms of life expectancy. That is somewhere in the mid-50s with regards to what their life expectancy is compared to 78 to 80 for most individuals that do not have these major mental illnesses. So now what I'd like to do is talk just a little bit about the program that we developed to start to address and learn about how techniques to address the health disparity of this population. Our program is called Access to Wellness, and I call what we do augmented prevention and recovery oriented primary care. That's a bit of a mouthful. At this point in time, I haven't figured out a cute little comment that describes that pretty well. So it's not simply importing primary care. It's augmented primary care, which I'll describe as we go along how that's a little bit different than just traditional primary care. It's been pretty clearly established that just only increasing access to traditional primary care is not the full answer for how to improve the health status of individuals with serious mental illness. There are some difficulties with that arrangement. So the aims of the program, the Access to Wellness program, are to design an augmented primary care service for individuals served in a community mental health center. That's our main inclusion criterion, that they be patients of our clinic. We conduct a health inventory of individuals served within a community mental health center as an element of their admission to the program. And then the third aim was to study health outcomes associated with importing an augmented primary care service into a community mental health center. We do have, just for those who are not familiar with community mental health centers, we have, in our particular place, we have a large variety of programs. Some of our individuals only come to our clinic about once every 3 months, but many of our individuals come to our campus and to our clinic on a daily basis. We have a number of day programs and rehab-style programs so we're engaged variably but quite thoroughly with a number of our individuals. The ones who are more likely to come more often are more likely to be health disparate and have the greater degree of serious and persistent mental illness. And so in that way, we're different than what might be a counterpart in a health center or a community health center, because we're engaged very regularly with a lot of our places. So for us, the concept of thinking about this new concept, relatively new concept, the medical home, it would make sense for this population that we work with to consider to go ahead and get some of their primary care needs met in a place like this where they have a lot of their time investment to begin with. So what is augmented primary care? I want to talk just a little bit more about some of the details of what that is. We do a health inventory on people as they enter into the program. So a health inventory is like a traditional history and physical that you'd get if you came to your new Welcome to Primary Care sort of physical exam, history and physical, but it's augmented. And what I mean by augmented in this case is that we have a lot of health risk behavior information in there, in a very sort of organized way, we've collected extensively histories of their drug use, their gender, sexual health, and health, their compliance or ability, their status with regards to routine maintenance checkups that are recommended, like mammograms, colonoscopies, things like that. So in a very thorough way, we go through a full list of that. We also try and understand, as an element of the health inventory, what has been their problem or what issues they've had with accessing traditional primary care, and try and understand how we can help engage with them to facilitate that. It's somewhat like an executive review of the health status and health behavior. From that, we review the results of the health inventory, lab tests are done, and then we meet again with the person and have a very thorough, individualized wellness plan that is created. The nurse practitioner that we have that works with the program goes through the whole health inventory and her history and physical with the patient and makes recommendations regarding her suggested things that individuals can do to improve their health. And then the patient expresses, based on their knowledge that they've received from the nurse of their own health status, expresses things that they want to work on. A common scenario for us, and I don't have numbers on this just exactly yet because we're still in the process of tabulating it, but a common scenario for us will be the nurse practitioner will identify smoking cessation as her number one goal. And the patient or consumer will often say, well, yes, I've tried that before, I'm not really ready to work on that right now, I really want to lose weight. And so in that kind of negotiated thing, we work with what the patient or the consumer wants to work with. So if it's weight, and we work on that, the nurse will bring up the idea of smoking cessation along the way, but we focus in our work with the patient on their identified preference. And then the third arm of, or third component to what we actually do clinically is what we sort of call wellness coaching and follow-up. So we help the individuals, once they've identified what their goal is, we help them to develop a goal that's workable and help them follow through with it in a manner that's defined by what they are comfortable with us engaging with. So if the individual, for instance, feels like they want to work on weight, often we have individuals who have quite a struggle with weight, and they'll say things like they want to lose 100 pounds. What our nurse practitioner will do is help them break that down into something that's a little more workable, like 5 pounds in a 1-month period or things like that, which helps us sort of reach targets along the way with the person. And if it turns out that they feel like impulsive shopping is a problem, we have staff that can go with them to the grocery store to help them, sort of coach them along with things that would help them eat. If we have a walking group, for instance, and individuals that want to join that, we call them, make sure they come with that. If they don't come to the walking group and they've said they want to, we follow through with that. So we have pretty intensive follow-through with that. In that way, I would suggest it's kind of like a disease management model that we use centered around the individual's preferences. So some of the techniques more specifically that we use to enhance what the patient comes into the clinic with that focus on those two elements, the health literacy and the health behavior of these individuals. We start with a health inventory, which gives us an idea of what their status is. We provide much longer sessions with individuals than they're able to get in typical primary care settings. So if you think of a typical primary care setting as being bound by 10 to 15 minutes of a visit, and very problem-oriented so that you can only really focus on the leading problem of the day, we're able, because of the way the program's structured, to spend a lot more time with individuals. So in looking through our time and our visits, they're frequently 30 to 50-minute visits. We give basic, accurate health knowledge to individuals, and all of the staff that are involved in the program are equipped with accurate health information. Some of the successes that we've had in the program really are based on the idea that this is a group of individuals who have somewhat been left out of knowledge about their health. And so we've uncovered things like individuals that don't really understand the problems associated with drinking sodas, full-calorie sodas, and how easy it is to substitute that for less-calorie sodas. That some of that information that many of us have incorporated in our lives for some time now is new information to these individuals. We had one patient who didn't understand, I think stuffed bell peppers is a recipe that she and her family make. She was sort of amazed at the idea of using a substitute turkey mixed in with hamburger to cut the fat down with that. So a number of examples of things like that we've been able to do that help people live more be better equipped with information, more accurate information. The reason that the second point there under health literacy, or I guess it's the third point, is important is because many of our staff are not medically trained staff. So the commonest staffing in a community mental health center actually have a social work background and or psychology, and so they're not equipped like nursing or medical staff would be with basic health information in the same way. They're caring people who work well with these individuals, but they may or may not have accurate health information on diabetes management or things like that. The other strategy that we work on are health behavioral techniques, and so this wellness plan is a bit of a contract with us. It gives us a common document that we work from with the patient, or that is is again defined sort of by the preferences of the patient. We work on with the concept of stages of change and trying to promote the individual if they're thinking about quitting smoking, for instance, but they're not really ready to make the change. We try to work with moving them forward in that continuum. We work with motivational interviewing techniques, which is a style that's been around in the field of community mental health or mental health for some time now, starting actually with trying to work on individuals in denial of a need for treatment for substance abuse. And the field in general has used a lot of those techniques for motivating behavior changes in individuals. We offer concrete, tangible support through case managers, and we have a peer support specialist or a consumer who helps us implement some of these plans. And then we've tried to work on, in the clinic itself, creating a healthy environment and social networks that are healthy. So we do have some groups that attend to health things, a group of people with diabetes, for instance, that go through a common experience on diabetic education, learn from each other with regards to very specific things like foot care and things like that. And then in some of our programs where patients are convened on a daily basis or where they come in, we have health exchange and health groups that go on there. And we also have provided a number of in-services for our staff through the health staff that we have. This is just a redepiction of the stages of change. I think probably most are familiar with that based in the work of Prochaska and DiClementi. It's a very old model. And motivational interviewing, just by way of summary, has to do with how you get a person to arrive at insight into the nature of the problem that you're trying to work with them on. So ORS is a common sort of mnemonic that's used, open-ended questions, affirmation of what the patient brings in, what they've said, reflection back to them on with regards to what they're saying, and a summary of a statement moving forward with regards to what they stated that they want to change. These are some of the results. I just have a couple slides left and a couple slides that reflect some of the results that we've had, just to give this group a flavor of the kind of health disparity that these individuals have. So based on our health inventory of the individuals, which we have about 180 people at this point enrolled in our program, in our population, access to wellness population, 51.1% of them have hyperlipidemia, compared to a Maryland average of 37.3% of the population, and national is about 37.4%. A history of ever having had a stroke, our access to wellness group is about twice that of Maryland in the national population. History of ever having had a myocardial infarction is also higher for our population by more than twice than the national average. Daily tobacco use is pretty compelling for any of you that follow tobacco and smoking statistics. 65.4% of our population are current smokers, which is a very high number. The other compelling information about our population, this is not new news. A number of studies have been done that look at the weight of individuals, but in looking at their BMI structure, a good number of our patients, 80 or so percent, are overweight, and then 43 of our population had a BMI of 35 or greater, which is in the category almost of morbid obesity. So they're a very, very overweight group of individuals. Some of the really basic results that we've had, and again, please forgive the lack of sophistication with regards to these results. They're just basic sort of percents. So like I said, we're in the process of, we're not even finished with a one-year follow-up with these individuals at this point in time. But so far, smoking rate having gone from 65.3% down to 43.3% in the population that we've worked with. So of all the people there, even those, we counted those who did not identify smoking as one of their preference things that they wanted to work on. We've been able to reduce the status of high cholesterol measurement by about half of the population. And we've had a tremendous amount of weight loss. I haven't figured out yet, or I'm still working on the best way to graphically depict that information, because we still have the majority of our patients are still quite a bit overweight, and we've had some very dramatic weight loss, several individuals having lost over 50 pounds since they've been involved in the program, and others losing losing varying degrees of weight, but changing category from being overweight, obese, and morbidly obese to a different category. So I need to depict that in a more sophisticated way. But altogether, of the 180 participants that we've had in the program, they've cumulatively, we do know that they have cumulatively lost more than 600 pounds. So in their description, in one of the surveys that we give on health disabilities, we went from a low number of only 14.7% of individuals saying that health disability never interferes with their life, never holds them back, in other words, from pursuing life to its fullness or participating fully in their recovery, to we've doubled the rate of that, so that now a third of the people that have been involved in the program say that they're not held back by their health status. So in summary, the benefits that we have, we've encouraged a number that we've had good success with regards to quitting smoking, lower cholesterol rates, a good number of individuals who've lost significant amounts of weight and now have more of a sense of control that they can lose weight and they know how to go about that and approach that. We have measured, sort of crudely, emergency department visits. One of the outcomes that we hope to achieve is less dependency on higher cost health care, and we're working on a project right now with one of the health providers to look at claims information with regards to that. We have individuals who are much more engaged with their personal health behavior. That we have a healthier, happier culture in our clinic, and we have more health-enabled mental health staff. And that concludes my remarks. Thank you very much.
I hope that you'll see the connection between these two presentations. We've never presented before, but we've talked a lot over the years on these issues. I'm actually going to present some research that I've done. I'm a health economist. I have no background in mental health. I actually stumbled across mental health over some conversations with people many years ago and started to get interest, and I had conceptualized this project that I did in the back of my head, and kind of like I'm very much interested in the measurement of patient preferences, and I said if I can demonstrate that I could measure a vulnerable population like people with schizophrenia, then it would be very hard to object that other populations wouldn't be able to do this. So maybe that was a very bad career move to start with the most difficult population, but it turned out that they weren't difficult. However, I did offer this research to the National Institute of Mental Health, and they turned around and said, why don't you go work on another disease? Schizophrenia is too hard to do this. So hopefully I'll be able to convince some people that you can do some preference work. I've got funding off a number of different groups. Janssen Seelag or Johnson & Johnson in Germany have been the primary funder of this research. I want to talk a little bit about patient-centered outcomes research, another term that featured quite prominently in the healthcare system reform that had passed this year. I want to talk about what I consider methods of patient-centered outcomes research, and then I'm going to demonstrate how my research on people with schizophrenia led to the creation of a new scale called the Clear Thinking Scale, which I think is a fine example of patient-centered outcomes research. I'm going to do this in steps, so hopefully you can follow along as the different steps of my research, and this is about my last 3 or 4 years. We started off with focus groups in Germany and 4 different regions, and tried to understand what people with schizophrenia wanted. Here we'd identified 13 patient-relevant endpoints. Issues of body weight that was discussed quite prominently, and some other issues that go down there, and these are the descriptors of the different outcomes that we found. How would we prioritize these outcomes? If you looked at how frequent these were discussed, things like body weight and other side effects of medications would feature quite prominently. But our research wanted to delve into that a little bit more. So we started with a ranking exercise. We got another population, again in Germany, had a trained interviewer, a psychologist. We recorded the interviews. These were actually done in a very safe environment for the patients, not in the hospital, but in the community. And essentially what we wanted to do was discuss the 13 endpoints with them. We were very open, very flexible. Patients could modify the cards as they saw fit. And essentially we asked them to take away any irrelevant endpoints for them and to focus on the most relevant endpoints And essentially, there were five most relevant, but patients could pick and choose as to their preferences here. So we're being very patient-centered here. We see here in the blue the important or the most relevant issues. Quite surprising in this graphic is that the 4 side effects issues, involuntary drooling, involuntary body movements, the EPS type of side effects, weight gain and sexual problems, ranked at the bottom of the list, with less than 20% of the population identifying them as most as important. Issues of clear thinking, social activities, daily activities, having a supportive physician featured quite prominently. The clinical outcomes of symptoms minimization and relapse were there, but we see that issues of relapse, only 50% of the respondents indicated relapse as being important. But we start to see some hierarchy here. Of course, one study does not evidence make, so we wanted to look at some other research methodologies here. And at this time, we were also asked, well, how does this compare with physicians? So we're going to do a different method here with a larger population, 105 outpatient diagnosed with schizophrenia, and we're also 160 psychiatrists. And here we had 20 treatment goals. Essentially, many of the goals that we had as patient-centered goals, but we're also going to put things that we found in the literature as being discussed, and we'd also done doctor interviews, and we're going to include a larger list here to kind of see how patients rank their outcomes in a larger set. Here we're going to use a method called the self-explicative or explicative score. Essentially, this is a combination of traditional Likert type ratings on a 5-point scale, but also a ranking, and I'm going to make a multiplicative score out of that and look at the relationship. Here, if we look at the ordinal aspects of the preferences, overall, patients and physicians, you can't say that they're completely different from one another. There is some relationship here. The things that tend to the top of the list and things that tend to the bottom of the list are somewhat the same. Let's look at the prominent differences. What are the things that physicians have rated higher than patients? Symptoms, self-confidence, communication, emotions, mistrust and hostility. These are very much medicine-oriented or clinical medicine or research medicine-oriented outcomes. These are weighted more highly by physicians. What is it that patients like? They want to focus on satisfaction, independence, improved physical health. So there's the link between the two research. But also things like hobbies and work. Look at the issues there. They want to do things. They don't want to be measured on some scale and improve a PAN scale. That's not their objective function. They want to have friends. They want to have a job. They want to be healthy. They want to get around. That's the type of things that they have. So here we could kind of say that this was merely semantics. But when we're looking for drugs on the market or developing new medications or new treatments, we find treatments that are physician-oriented. These are the outcomes that end up on large studies, not these outcomes. The subtle differences here could account for the very high rates of discontinuation of the drugs. Are we developing the wrong types of drugs? Could we focus on that? Thinking in the drug development program, we start out with 100,000 molecules and start narrowing it down. Are we narrowing it down in the wrong direction? And would patient-centered outcomes research lead us into a different direction? Again, I'm going to show you another study methodology here. We're going to narrow the outcomes down here just to 7 outcomes. We're going to use some experimental design, some engineering techniques to develop a questionnaire called a conjoint analysis, and we're going to focus on patients that, again, recruited through physicians diagnosed with schizophrenia for more than 1 year, but not having acute symptoms. This is the type of task that we are going to present people. This was the task that the NIMH quite politely said that patients could not do. So here it's a conjoint analysis task. So instead of assessing individual aspects individually or linearly, we're going to assess them as an array. And here, to do that, we kind of assign levels to the attributes. So not only do we have, say, body movements, but we talk about the degree to which body movements are limited, or daily activities, to what capacity of the daily activities, and then we make a series of profiles here and identify them. We present them in the third person. We were traditionally just saying this is outcome 1 and this is outcome 2, but quite often patients are very familiar with assessing their own quality of life. Essentially, when they were left generic, they thought that we were trying to assess their health, and instead of identifying their goals and aspirations, they were identifying the patient that was more like them. When we moved over to third person presentation, and now in the application of conjoint analysis, this type of choice mechanism has now become more prominent based off this study to look at this approach. Essentially, we run a series of this across a population. Here we have presented to 100 patients, again in Germany. And this is the weights that we are focusing on. We could look here at the odds ratios. Essentially, a logistic regression has been run on the choice of the profile that they would like to be. Most issues here is body movement. Here, we've put all of the EPS movements together, even though they individually ranked quite low. We've kind of made a super attribute out of that. We probably went a little bit too far in making that attribute a holistic attribute, but when put together, maybe they feature quite prominently. But again, issues of daily activities, clear thoughts, and I'm going to talk a little bit more about that because that's where my research has come from. If we look at the least aspect, we look here that everything is statistically significant in terms of importance. We've done a lot of work up until now, so of course we didn't put anything that was irrelevant onto the list because we really wanted to focus in on this aspect. But the two clinical aspects, disease symptoms and relapse, are the things in this particular model that patients are ranking the least. And the impact of these outcomes are not impacting their choice as much. This led us towards a research question. I presented this at several places around the world, and people turned back and said, what is clear thinking? In many of your studies, you've demonstrated this issue of clear thinking. We don't understand what you mean. But because I've done patient-centered research, instead of walking in the door with defined properties, patients could essentially choose what they like. So I said, I don't know. It was something that patients wanted. So essentially, we just embarked on a study using a kind of phenomenological approach, looking at the patient's definitions of clear thinking, and then some more in-depth interviews in the US, both with patients and clinicians, to kind of develop a theory of clear thinking grounded in a very pragmatic point of view. This is what I think patients see as clear thinking. In terms of getting published, again, I'm having some difficulty here because I go off to the psychologist and they say, we don't understand this. You've included too many different issues on the one thing. And are you talking about symptoms? Are you talking about outcomes? Are you talking about functioning? Well, actually, a patient doesn't mix those. They live these things at the same time. So I hypothesize, based on my interaction with patients, that clear thinking is defined by 4 broad domains that have subservient issues: staying organized, making sense of the world, feeling clear-headed, and also in expressing thoughts and feelings. And this was something that I really didn't expect to come out. Having relationships, communicating to others, having a full and bright and vivid life. That's what was important to patients with clear thinking. What did we do next? We went and made a scale. So based off the same transcripts, I went into item generation. I identified from these 4 theoretical constructs, about 120 items, reduced it down to 28 items, and then went to the outpatient population. Again, here, this time I've moved over to the US to do my research. This is coming from the same patient population that Anita was discussing earlier on. And here we're looking at patients that, again, have this persistent severe mental illness. The findings that we have, the Cronbach's alphas for these theoretical constructs, and again, these theoretical constructs are only grounded in the patient's experience, turned out to be quite robust. Overall, the scale of 28 items produced a Cronbach's alpha of 0.93, very strong for a scale. And having discussed with other professional scale developers in the area of patient-reported outcomes in schizophrenia, most other scales have Cronbach's alphas in the 0.5 to 0.6 range. So this was quite remarkable and kind of quite competing with the traditional notion that a scale had to come from the same type of theoretical grounding of being an outcome or being a symptom. So these things do belong with one another, and actually if we looked at the scree plots that would be generated here, I could say that these 4 subdomains exist as singular domains, but if we look at them jointly, there's no evidence to pull them apart. So again, one could think about these 4 things as being subdimensions, but quite robustly, clear thinking is a broader construct that covers all 4 of these aspects. Well, so what are the conclusions that we have here? If we are going to move to a world of comparative effectiveness research and this patient-centered outcomes research institute that is being developed as part of the health reform of this year, we really need to focus on patient-relevant outcomes. And we need to do that as researchers. I say that, if we look at genetics or brain scanning and how much research has been put into these over the last 10 years, very little research has actually been invested in understanding the preference component. But I argue as an economist that a preference component to healthcare, particularly for chronic disease, is going to play a very large role in particularly understanding riddles such as compliance and adherence. More attention has to be placed on the identification and valuation. So we could have worked backwards. I started with patient preference analysis and moved towards a scale. I could have also taken an existing scale and moved backwards and used these type of methods to identify within the existing scale which aspects patients valued more robustly. The patient's voice in comparative effectiveness research needs to be supported by scientific evidence. Agencies like AHRQ and this comparative effectiveness agency are moving towards the notion of just having a patient representative or an advocate sit on their board or sit on their council, and that should be enough patient-centeredness. This is not right. We need to understand patients. If we are going to serve patients, then as a matter of basic research, we have to understand what are the needs and wants of patients. Here, qualitative ranking and rating, conjoint analysis, and other preference methods will play a beneficial role as research tools in the movement towards patient-centered outcomes research. I have a couple of advertisements as I finish off. My vision for patient-centered outcomes research does not just focus on mental health, but I was actually the founding editor of the first medical journal in the world to focus only on the patient. So The Patient, as it's called, is the first patient-centered outcomes research journal, and it was a joint venture between the Bloomberg School of Public Health and Walters Kluwer, and we're now just finalizing our third year of operations, moving into our 4th. And if you're interested in these methodologies, At ISPOR, a professional society focused on outcomes research, I run a task force on these type of research methodologies. And also a working group on these type of methodologies that focuses on education. And also I chair a conference devoted on the application of conjoint analysis in healthcare, which will be held in Newport Beach this October. Thank you.
Thank you very much, Dr. Bridges and Dr. Everett. At this point in time, we are open for questions, both from the live audience here as well as those watching online. And just a reminder, if you are watching online, that we have a new system, so if you're not familiar with this one, you simply click on the little question mark icon down at the bottom right-hand corner of your screen. So if you click on that, you should be able to email us a question for either of the presenters.
For Dr. Everett, I was wondering, do you actually serve the homeless population at all, or is it just mainly focused on the average citizen? A lot of our individuals are homeless and or have been homeless at varying points in their lives, and so one of our, if a person comes into our clinic and they're actively homeless, we do try to get them housing as a high priority. So it's a big problem with our population. The health, the overall general health of individuals who are homeless is a very significant problem for that population. So.
I have a question for Dr. Everett. I just wanted to ask, I mean, the program, the wellness program, access to wellness program, what about the cost of the program? I mean, are the patients insured, or, I mean, who pays for all the, and particularly the social, the treatment part is okay. I mean, it can be assessed that, okay, this is the cost of the drug and stuff like that. But the other part, how to...
So, like is the tradition of community mental health, we've sort of cobbled together different resources for the program. So it's the first 3 years of the program primarily were funded by a special grant that we got from the state, not a research grant, but a services grant from an entity that was called the Community Health Resource Commission, that was set aside to address health gaps in the Maryland system. And so that paid for the salary of our nurse practitioner and some of the research components that we had that were part of that. We partnered that together with case management. In Maryland, case management can do some degree of resource linking, so we had some degree of that. And then our peer support specialist, we also paid her out of the original grant that we got. Right now we're in the process of analyzing moving forward how we're going to pay for the service, and we're working with what we would, a fee for service for that. Now that we have experience with the population, kind of know that it takes more time. For instance, it's a more complex visit than a traditional, quicker primary care style visit. We're hoping to be able to have the service at least break even. That's our goal, and we're working with our hospital administration to do that. We're also trying to develop some arrangements with some of the medical health payers in Maryland, which is not unusual in state systems. Mental health care is carved out at a high level from health care, and so the health payers don't have as much interest in how many mental health services our patients use, or they don't divide people out by who comes to our community mental health center and who doesn't. And so we know that our patients are very high-cost health utilizers. They go to the emergency room a lot. They have a lot of sort of high hospitalization costs. They have a lot of the kinds of conditions that they don't treat earlier as a group, and so they incur high costs later in the system. So we're trying to study our program with regards to its impact by intervening earlier and working more up front on the health behaviors so that we can avert longer-term care costs down the road. And we think even in the 3-year period, which is relatively short in the life of a person, we've at least been able to demonstrate some reduced use of emergency room visits and things like that. So we're hoping to have some sort of arrangement with some of the payers that would give us some special funding for at a case rate for the individuals that are in their system high users of medical services. That's kind of a long answer, but they are a very high-cost population.
This question is for Dr. Everett. So I was really interested in that decrease in the smoking rate that you saw. So what did you find was successful in terms of getting the people to quit smoking? Did you offer any programs for them, or did they do things on their own? What worked?
Just repeat the question.
But this was a question about what worked with regards to the smoking cessation.
Yeah.
So individuals with our kinds of mental illnesses typically smoke a lot more. What we showed there was just the rate, but they'll also smoke more in terms of numbers of packs of cigarettes per day and things like that. And so they're harder in many ways. There's some people, that's part of why some healthcare providers are a little bit resistant or reluctant to even address smoking cessation with individuals. They'll often hear, well, it's the only pleasure that this patient has, and so we're not even going to bring up about quitting smoking. So some of it we feel like was just bringing it up and creating an environment where they could discuss it with individuals. We use a full array of products that are available as well as supports, and so we did callbacks to individuals if that's what they wanted and what they felt like would help them support smoking cessation. So without that, we've used patches, we use other nicotine replacement products, and we also have used the new product that's available to us called Shantax for a number of individuals. We follow them very carefully. That's a product that it has some lore associated with it as being potentially problematic with regards to people who have mental illnesses, but we didn't not use that. We just followed them very closely and had some good success with that. So we used the whole gamut of smoking cessation things that are available. But I think the main thing that was different about what we do than other attempts they've had before is hanging there with them. Support
follow-ups.
them, follow-ups, and follow them closely.
I think my question is for both speakers. So we're talking about patient-centered care, but I do wonder, especially in mental health, what's the role of carers? Because depending on how severe these patients are, they might have carers. So what's their involvement? What level do you, because we're talking about the patient per se, but of course they need support at home, or sometimes they need extra caring. How do you get involved into that care, into that patient-centered care? Where does it fit?
So there has been some preference work comparing carers with patients, and there sometimes is some conflict, but between their carers have different objective function. The importance of carers, there's also been some research that says that carers of patients with unstable schizophrenia actually have a far lower quality of life. Their quality estimates are actually much lower, so it has an impact on the family. But I think from a community point of view, so certainly from the patients that I have spoken to, having someone is important. When you don't have someone, that's where I think community roles have a major importance. Filling that spot or getting them back into a position, as some of the patients that I've spoken to have talked about. Oh, look, if I don't really want to go and speak to my sister because I don't want to show her that I'm unstable. But if you can get them stable, then they can get back into a relationship with their family, and that helps them reinforce. So there is it's a very complex relationship there.
I certainly agree with that. In our experience, it's been really interesting for me since I've had some exposure as a clinician in other countries where families are much more involved, sometimes by choice and other times by necessity. Because we have entities like case managers, and you'll go other places and family members will say, in Eastern families, wouldn't that be the job of the sister to do that job? Why do you need a case manager to come in and do those kinds of things? And so we're really trying to work with what is the best role for families. A lot of times by the time individuals get to our programs, they have had issues with their family becoming burned out or alienated in one way or another. And so part of what we're trying to do is work to repair relationships with families. And we really didn't design that into the Access to Wellness program, but I think we might do that. It's certainly a resource that individuals have, some individuals have.
Hi, Anita. Thank you both. It was a great presentation. I'm Linda Rosda from the School of Nursing, and I've done research with the families, and it was really striking to me to hear you talk about what patients valued as things that they wanted to work on. And for many of the families that I've spoken to, they share similar goals and endpoints that they want for their family member. They want them to, as they say, have a normal life. They want them to have a job. They want them to have a steady relationship. They want to have them live on their own. The things that make people happy in normal everyday life. And that's what they want for their relative who has this serious mental illness. It's really interesting to me that they're so in tune together with what you said. I have a follow-up question. I'm interested in your clear thinking scale, and where do you think are the next steps for that scale?
Thank you very much. But for the people at home, I'm not sure they heard the comment, but it was a reinforcement of the family's aspect, and I think that very, very much ties into the principle of recovery, which is the objective here is, most of the large studies focused on schizophrenia try and focus on all-cause discontinuation. It's unclear how that relates to normality or integration back into the community or into the family life. So that's one of the issues that I have, is the objective function for developers of drugs and programs. It could be heading in the wrong direction. And if you look at the rates of discontinuation of all the products that are available, none of them do very well in this aspect. So I think that a major shift is needed to refocus that there. What's the next step for the clear thinking scale? I've got to convince some people that it's valuable. The scale has been translated into an additional 5 languages and is going on a comparative effectiveness study in Europe, a multi-country clinical trial. And so hopefully I'll be able to get the full validation and be able to do the confirmatory factor analysis, because you're familiar with the sample sizes that are needed and the ability to identify the unique variants accounted for. But also I think it has some practical aspects. Some of the clinicians here that I've been working with have already started to incorporate the concept into the management of patients. And I think that's where it has the practical value. So I'm kind of working at both ends. Also, my kind of combined between both our research interests, the next thing that I would like to do is identify what patients with schizophrenia consider full health. Because we have scales that measure full health in our other patients. The work of a number of researchers across the campus here has identified those with somatic illnesses feel that their mental health is neglected. I wonder what will happen if we focus on what are the health needs of the seriously mentally ill. I think combined from both our anecdotal research and preliminary findings is that the somatic health is very much neglected, but it's a complicated story. And I would like to look into that. So that's my kind of on my wish list, is to kind of finalize validation of the clear thinking scale, but use it as a mechanism to kind of say, well, we could also generate another scale focused in on full health, and currently we don't know anything about the perceptions of patients with severe mental illness and on full health.
Okay, we do have a couple questions from our online audience. One of the questions had to do with, for Dr. Everett, and the patients that you see at your clinic, wondering whether there are any differences in outcomes based on race, if you're seeing any differences, any kind of racial disparities for the patients that you're working with.
Not anecdotally. We haven't fully analyzed that information. There is our population. This particular population is about 50-50, which reflects the demographic area that our clinic is in. So it's a good, compared to national averages, for instance, we've oversampled for African Americans, for instance. There's not really a tremendous difference that we've separated out. You might expect to find some differences with regards to hypertension in particular and stroke risk, but we haven't really got that level of detail at this point in time. So not really that we can, not really, I guess the answer would be no, not really noticing particular outstanding differences. One of the things that's really popped out for me that is interesting in thinking about the general comparative to the general population is the number of people in our clinic who've never been married. So there's a high divorce rate in people who have mental illnesses, but I didn't show the statistic, but I think something like 80% of our individuals have never been married. So there's social isolation, and if you think of marriage as having some health protective factors or having a continuous person in your life, this really does outstand. It's outstanding in our group. It's a very different parameter that was a little bit unexpected for me.
Okay. We also have a question for Dr. Bridges. What do you think of the notion of patient as consumer and watching what patients go after rather than what they say they want, i.e. their health-seeking behaviors rather than what they say their preferences are?
So this is an interesting issue that needs more empirical research. But of course, I'm one of the first people to really focus on their stated preferences. So making that link is difficult because I don't think we fully understand what they want. And I think that that's one of the issues that has brought us together in terms of connecting a system. An empowered patient is one that has a healthcare system that enables them to achieve what they want. And one of the problems is that from basic research through to how healthcare systems are paid for have an objective function that's very different to the patient. So it's an uphill climb. Even if you are the most strong-willed patient, it's actually very difficult to find the things that you want when the healthcare system may be trying to can push you in a different direction. And this is where I have some serious concerns with some recent developments towards paper performance or even patient paper performance, which is trying to one of the conclusions from some researchers is if patients aren't compliant with what we set out, why don't we just pay them to be compliant? And I think that there's some real social justice issues there. Who's wrong and who's right? So that's where I become a real patient advocate, I suppose.
Any other questions? Here? I think that concludes our session for today. I want to thank everybody for joining us, both online and live, and encourage you all to join us again next month on September 15th, where we have a discussion about the reemergence of bed bugs and how that is being addressed on a public health status. So thank you all for joining us.